Of labor. Labor, the process of uterine contractions leading to progressive effacement and dilatation of the cervix and birth of the baby. Induction of labor, artificial stimulation of the uterine contractions before spontaneous onset of labor with the purpose of accomplishing successful vaginal delivery. This includes both mother with intact membranes and mother with spontaneous rupture of membranes, but who are not in labor. Augmentation of labor refers to the stimulation of ineffective uterine contractions that are considered ineffective because of failure of progressive dilatation and fetal descent after spontaneous onset of labor. Indications of induction of labor: when the woman's life or the well-being is in danger, or if the fetus may be compromised by remaining in the uterus any longer. Maternal indications: severe preeclampsia or hypertension, urgent. Fetal death, chorioamnionitis, urgent. PROM, post-term pregnancy, abrasion placenta. Medical conditions including DM, heart disease, renal disease. Significant APH, urgent. Fetal, usually for pregnancy termination due to significant fetal compromise. IUFD, that is intrauterine fetal distress, death rather. Fetal anomaly, incompatible with life. Severe IgR, urgent. RH isoimmunization, macrosomia. Logical. History/risk of rapid labors. Distance from hospital. Psychological indications. Contraindications of induction of labor. Generally, the same for spontaneous birth or vaginal birth. Vaginal bleeding, known as complete placenta previa or vasa previa. Abnormal fetal position, transverse. Classic uterine incision. Umbilical cord prolapse, macrosomia. Severe hydrocephalus. History of uterine surgery involving myometrium, genital herpes infection, cervical cancer, distorted maternal size, especially the pelvis. Complications of induction of labor: maternal, emotional, fear, anxiety. Uterine inertia, prolonged labor, interpartum infection, violent labor, abrasion placenta, uterine rupture, cervical laceration, hypofibronogenemia, amniotic fluid embolism, postpartum hemorrhage. Fetal complications of induction of labor: hypoxia, iatrogenic prematurity, wrong dates, prolapse cord infection. Indications for augmentation: uterine hypocontractility after the maternal pelvis and fetal presentation have been assessed. Contraindications of augmentation: placenta or vasa previa, umbilical cord presentation, prior classical uterine incision, active genital herpes infection, pelvic structural deformities, invasive cervical cancer, pre-induction cervical ripening. Cervical ripening is a process of effecting physical softening and induction and dilatation of the cervix in preparation for labor and delivery. Condition of the cervix is important to the success of labor induction. A predictive method of an outcome of labor is known as the Bishop score. Was described by Bishop, 1964. The highest score is 13. A score of 9 indicates a high likelihood for successful induction. A weight for spontaneous labor. A score of 6 ripen the cervix. Bishop's score of 4, less than 4, indicate unfavorable cervix. Then a score of 0 managed for CS. So that is the Bishop's scoring system used for assessment of inductivity. So we've said the highest score is 13. So from the left side, we can see the score of 0, 1, 2, 3. So dilatation, if it is closed, the cervix is closed, that is 0. 1 to 2, it's 1. 3 to 4, 2. 5, 3. Effacement, 0 to 30, effaced, 0. 40 to 70 to 50, rather, 1. 60 to 70, score of 2. Then more than 80, score of 3. Station, if it is minus 3 to minus 3, that is 0. If it is minus 2, 1. If it is minus 1, score of 2. If it is plus 1 or plus 2, score of 3. Cervical consistency, firm, 0. Medium, 1. Soft, 2. The maximum score there is 2. We come to the cervical position. If it is posterior, 0. If it is mid position, 1. If it is anterior, 2. So most midwives will induce if the cervix is 2 centimeters dilated, 80% at first, soft, mid position, fetal position is at least -1. Techniques for cervical dilatation. Divided into 2. Pharmacological techniques. Prostaglandin E2, dinoprostone. Prostaglandin E1, misoprostol. 2. Mechanical techniques. Transcervical catheter and extraamniotic saline infusion. Cervical dilators, membrane stripping. Methods of ripening the cervix. Cervical massage is done. It helps to release local prostaglandin. Stripping, wiping of the membranes, and the time is allowed for ripening at 41 weeks. Prostaglandin E2, e.g. misoprostol and dinoprostone, are given vaginally. 12 hours is allowed for cervical ripening. Foley's catheter is inserted through the cervix and placed in the extraamniotic space. Working for cervical dilatation, whatever method is used, works by release of prostaglandins. So 1. Prostaglandins, mode of action. They act on the cervix to enable ripening by a number of different mechanisms. They alter the extracellular ground substance of the cervix, and prostaglandin increases the activity of collagenase in the cervix. They cause an increase in elastase, glycosaminoglycan, dimethyl sulfate, and uronic acid levels in the cervix. A relaxation of the cervical smooth muscle facilitates dilatation. Prostaglandin allow for an increase in intracellular calcium levels, causing contraction of the myometrial muscle. Prostaglandin E2, that's 1 here. Administered intracervical or vaginally, 0.5 mg intracervical, 10 mg vaginal insertion. Should be administered at or near labor and delivery. Bathing suit to monitor fetal and maternal and uterine status. Continue monitoring for 30 minutes to 2 hours after administration. Oxytocin should be delayed for 6 to 12 hours after the last dose of gel. Complication: uterine hyperstimulation. Prostaglandin E1B, misoprostol Sedatec. It's a tablet containing prostaglandins. Should be administered at or near the labor and delivery. Bathing suit to allow continuous monitoring of fetal and uterine status. Uterine hyperstimulation is a complication. Oxytocin should be administered 4 hours after the last dose. Number 2, stripping of the membranes. Stripping of the membranes causes an increase in the activity of phospholipase and prostaglandin, as well as causing mechanical dilatation of the cervix, which releases prostaglandins. The membranes are stripped by inserting the examining finger through the internal cervical os and moving it in a circular direction to detach the inferior pole of the membrane from the lower uterine segment. Risks for this technique include infection, bleeding, accidental rupture of membranes, patient discomfort. Complications: maternal fetal infection, PPROM, uterine cord prolapse, precipitate labor and birth, personal discomfort. Before induction, obtain a 20-minute NST to assess fetal well-being. Evaluate maternal vital signs, especially BP. Evaluate the patency of the IV site, if IV is ordered. Establish indication clearly. Informed consent. Confirmation of gestational age. Assessment of fetal size and presentation. Pelvic assessment. Cervical assessment. That is the Bishop score. Availability of trained personnel. Methods of induction: natural, that's the breast or nipple stimulation, sexual intercourse, membrane stripping, amniotomy, acupuncture or aquapressure; mechanical, balloon catheters, luminaria turns, synthetic osmotic dilators; chemical, nanomonal, include herbs, evening primrose oil, homeopathic prep, enemas, castor oil; hormonal, oxytocin, prostaglandins, PGE2, misoprostol, relaxin; nitric oxide donors, mifeprostone; amniotomy, that is artificial rupture of membranes; aroma. Vulva is clean, vaginal examination is done, amnio hook is inserted through the cervix, and membranes are ruptured after the fetal presentation is evaluated. Fluid should be clear and cloudy without odor. Fetal arteries are assessed continuously for at least 20 minutes. The next 20 minutes. Complications include umbilical cord prolapse or compression, maternal or fetal infection, and or distorted fetal head. Oxytocin B. An IV fluid is mixed with oxytocin. The goal is to establish a regular labor pattern that will produce cervical dilatation of at least 1 cm per hour in the active phase of labor. Complications include uterine hyperstimulation, more than 5 contractions in 10 minutes. Uterine hypertonus. Uterine resting tone is greater than 25 to 30 mm per mercury, depending on the type of uterine pressure. Catheter. Uterine contractions are longer than 90 seconds in duration. Coupling of contractions, fetal distress, increased incidence of CS, cesarean delivery, neonatal hyperbilirubinemia, possibly from red blood cell trauma, from intense contractions or decreased maturity of the neonate. Monitoring labor after oxytocin induction. Oxytocin should be given after cervix has ripened. Monitor labor progress using pathograph. Book the mother for theater in case of cervix, in case the cervix does respond to the ripening and induction. After the administration of oxytocin, continuously monitor fetal heart rate and uterine activity, especially uterine resting tone frequency and duration. Assess the maternal vital signs. Temperature should be taken every 2 to 4 hours unless an amniotomy has been performed, and then every 1 to 2 hours. Limit vaginal examination, especially after membranes have ruptured. Maintain input-output records. Watch for signs of intoxication, water intoxication, dizziness, that is dizziness, headache, confusion, nausea, vomiting, hypotension, tachycardia, decreased urine output. Evaluate IV site for patency and rate control for correct rate at least hourly. These are the nursing diagnoses for induction of labor. Anxiety related to planned childbirth and outcome. ineffective tissue perfusion, that is uteroplacental with altered oxygen to fetus related to strength of uterine contractions, acute pain related to prostaglandins action on the uterine muscle, nursing interventions, decreasing anxiety of the patient by teaching the patient, promoting tissue perfusion and oxygen supply to the fetus with through monitoring of the fetus, and the mother should lie in lateral position to enhance placental perfusion. They should also have an oxygen mask set up in the mask ready and administer as prescribed. Controlling pain is another nursing nursing diagnosis or nursing intervention. Evaluation, outcomes, verbalizes understanding of the understanding of the induction process. No evidence of hyperstimulation or fetal compromise. Labor progressing with no pain, with pain controlled rather. So these are the nursing management during the induction of labor also. So one is explain and weigh the mother. Explain and weigh with the mother the risk of induction versus the risk of expectant management. Explain available methods, advantages and the disadvantages plus cost. Given a formal explanation, written formal explanation for further reading. Obtain of consent and assess appropriacy of cervical delivery. You assess your knowledge and skills in entire methods of induction, their sequence and contraindications. Anticipate complications and be ready to respond appropriately. Ensure sepsis during the procedure to prevent infections. In hyperstimulation, give tocolytics and discontinue, monitor fetal well-being. In fetal distress, tocolysis is considered. Perform V before and after ARM to minimize the risk of cord prolapse. Titrate oxytocin to 6 to 7 contractions every 15 minutes. Oxytocin are started immediately after ARM to reduce chances of PPH. In absences of liquor, close fetal monitoring and amnio infusion may be done. Prostaglandins more preferred when membranes are intact. If ripening is done, perform Bishop's score after hours. Ensure mothers assure mothers of the success. Place prostaglandin tablets to the posterior fornix of the cervix and wait for 6 hours. So basically assess for meconium after ARM. Also, on failure of induction, refer the patient for CS depending on urgency. Encourage routine elective induction of labor and discourage routine induction of elective induction of labor. Prepare mother for CS. So those are the key points. So patient education is very crucial in this process. So thank you.